I work out of Central Indiana. I'm a foot and ankle surgeon. So in this case, we're going to be doing a lateral ankle ligament reconstruction for repair of the ATFL using 4.75 millimeter anchors as well as the BioBrace 250 millimeter by 5 millimeter.
So we can see we have the BioBrace graft here. Has not been hydrated yet, but does absorb about 300% of its weight in fluid. So a lot of times I will hydrate this either with PRP or bone marrow aspirate concentrate, or you can hydrate it with saline as well, which is a common thing to do. So we can take our bone marrow aspirate concentrate here, and it comes in a tray with the BioBrace, and essentially whatever biologic you want to use, hydrate it. You can see now it holds quite a bit of fluid after you use your adjunctive. And you can see just by squeezing it out how much fluid actually is contained within there. All right, so we'll start off by marking some of the anatomic landmarks. Obviously, we're going after the anterior talofibular ligament, the ATFL here. So we have our distal fibula, medial aspect of the ankle, lateral aspect of the ankle, standard arthroscopy portals. And our accessory incision is going to be just anterior to the distal tip of the fibula and approximately 1 centimeter distal in this region here. And then eventually when we get to our Gould modification, we'll be passing some sutures, which are going to be located just anterior and just posterior to this spot to reinforce with the accessory retinaculum after our BioBrace has been implanted. So traditionally I will start out with insufflating the ankle joint with some fluid, whether that's saline or a local anesthetic of choice. And small incision. I will take a hemostat and bluntly probe directly down into the ankle joint to create the working space for the arthroscopic camera through the medial portal. We have our trocar. So we have a nice view of our ankle joint here. You go through and perform your debridement of your ankle joint, remove any bony spurs, any intra-articular pathology such as an osteochondral lesion is typically addressed before you're going to be doing any of the soft tissue repairs for this type of procedure, just because once you actually have the anchors in place and the ligaments are reinforced, it's a lot more difficult to actually access depending on the location of an osteochondral lesion, if it's more central or more posterior on the ankle. Once those ligaments are reinforced, it's kind of difficult to get back to those locations. So once you've cleaned out your ankle joint and you actually are ready to perform your ligament repair, this will establish our anterior lateral arthroscopic portal here as well. Just got to be careful about the superficial peroneal nerve branches in the area and avoiding iatrogenic damage to those with this procedure. Typically, with these chronic lateral ankle injuries, you're going to have quite a bit of synovitis, especially over where the ATFL would lie. So right now, we're just in front of the anterior distal aspect of the fibula where part of the ATFL attachment would traditionally be seen, and we're debriding away some of this synovitis in the area. And you can use either the arthroscopic shaver, or if you have an ablator, sometimes that can facilitate the ablator can facilitate some of the adhesions that you would see from the remnant ATFL on the anterior aspect of the fibula. When you're doing the open repairs, you have direct access. You can use a rongeur or whatever instrument you'd like to use to freshen up the bone on the anterior aspect to facilitate the actual adherence of the repair that you're doing. When you are doing this arthroscopic technique, you rely on the shaver or the ablator to actually prepare the bone for ligament attachment and extensor retinaculum reinforcement attachment. So we can start to see the distal anterior aspect of the fibula here now after doing some debridement. Now that we have some good debridement on the fibula, it's a good idea to trace out the borders for the eventual anchor placement for both the BioBrace implant with the anchors as well as the all suture anchor that will go in here for the Gould modification, typically just at the level of the talar dome or just below to reinforce your repair with the extensor retinaculum. You do not want to be inside of the joint when you're placing that anchor. That can cause some irritation afterwards with impingement inside of the joint. So getting a good outline of the extent of your fibula, the most lateral aspect, the most inferior aspect down here, will just ensure proper placement and avoid those impingement symptoms. So in the operating room, we're typically utilizing a mini C-arm and can rotate that around the ankle to get the proper positioning to view these guide wire throws for the eventual anchor placements. So first throw I typically will be through the distal tip of the fibula. We will poke this wire percutaneously through the skin and find our starting point. Want to make sure you're not inside the ankle joint and creating impingement. You want to be placed right in the central portion of the distal fibula, again in a slight anterior to posterior angle. So we can see on the AP view here that we've got it in a good part of the fibula. So now we're going to take a lateral and make sure that we also have good positioning. Okay, now we can see on the lateral view that we have a good position with a slight A to P angulation within the intermedullary canal of the distal fibula. So now we are ready to make a small incision over our guide wire to be able to drill and place the anchor, and this will also serve as our portal for the talus anchor as well, and the eventual suture passing for the Gould modification. And we'll take our drill and drill sleeve, and again under fluoroscopic guidance, we're drilling into the distal tip of the fibula. With the arthroscopic approach here, usually when you have an open incision, you can mark on the drill how far you do need to go, but since we do have a lot of real estate in the distal fibula here, you just want to make sure you can get the full advance of the anchor in. So if you're drilling approximately 20 millimeters or 2 centimeters, you should have plenty of room to get that anchor in there with the BioBrace. And sometimes when you drill, if you have this on someone with some pretty hard bone, that wire will come out at this step as well, but you've already made your pilot hole for the anchor, so that no longer actually needs to be in there. I would keep the wire around just because if you do have trouble finding your anchor hole, sometimes it's helpful to place that wire back in just so you have an idea of the angulation of where you're putting the anchor in. So next we will take our 4.75 millimeter twist-in anchor, and we have the eyelet here. I like using this anchor because it is a very snug fit, and especially without the direct confirmation of seeing the anchor placed within the bone, you don't want it sliding around, especially when it comes time to place that talus anchor. When you're putting it into the fibula here, you can advance it and get a little slack on the BioBrace implant, but when you're putting it into the talus, that's when we're really worried about the proper tensioning. So I will pull this BioBrace through by a couple millimeters as well, just so it does have proper seating in the fibula, as well as making sure that it doesn't pull out when you're tapping the anchor through. So the reason for doing the slight A to P angulation for this anchor in the BioBrace implant is that is the natural trajectory of the ATFL ligament. It doesn't come straight off the distal tip of the fibula traveling down. It does have an anterior angulation going towards the talus, so that's the reason for having this go in at this angle, is we're trying to recreate an anatomic repair for the ligament. And just to make things easier, if you can start out with the longer end of the BioBrace facing anteriorly towards your eventual anchor placement for the talus, that'll just make your life a little bit easier so you're not twisting around with it on the other side. So again, sometimes it's helpful to keep this wire so you can find your previously drilled hole, so you're not malleting in and guessing on where your anchor might be placed. So that looks like a pretty good position there. So we know the trajectory we need to put in our anchor, and a lot of times I'll have my assistant or scrub tech pull out that wire and insert the anchor in the same trajectory directly after that. We will take our mallet and gently start to tamp the anchor in until we can feel it start seating. There we go. We can see through our fluoroscopy, our cannula, that is metal that we can see going in. Then when you start to feel some resistance, then we utilize the twisting mechanism on the anchor. And then when you do start to get it tight, you'll hear that squeaking motion on the anchor. And by the time you actually get the thicker part of the advancing cannula and the anchor reaching the tip of the bone, then you know that you're seated pretty well within the distal fibula is the tip of it, and that's when we know it's in bone. All right, now that we have our first anchor in the fibula implanted, you do have these two available sutures on this anchor that you can utilize if you would like. I do not use them, so I will take them out at this point and discard them. And then the driver comes straight out. Want to make sure you have proper seating, so I usually give a little tug on the anchor and the BioBrace, make sure that's actually in there so it feels pretty snug there. Attach the other end of the BioBrace to the drape proximal, so that when I'm placing my second wire for the talus anchor, I'm not accidentally getting this wrapped up in the process. All right, now we're getting ready to put in the guide wire for the talus anchor. And what we're aiming for here, we can see the lateral process of the talus, and just anterior to that is our anchor placement. We want to avoid the articular cartilage, and this is just in the proximal part of the neck of the talus. And again, this is the anatomic natural position of the ATFL. So again, we're just trying to create. So this is one of the most important and careful parts of the entire procedure, because you definitely do not want to be in the ankle joint or the subtalar joint. So you want right in the central part of the neck of the talus, and this looks like a pretty good position here on our x-ray. So go ahead and drill this, and you can go straight lateral to medial, or you can take a little bit of an anterior to posterior angle. And then after I have placed this wire, a lot of times I'll do our perfect circle technique and get a straight up and down view of this wire to make sure our placement is right where we want it, and that does look pretty good right there. And then again, at this, it's the same technique that we just used to place the fibula wire and drill over. Just this time we're doing it in the talus, and typically I'll switch to an anterior ankle x-ray again, just so that I make sure I'm not going too far medial and violating soft tissue structures that I don't need to. At this point, we are flush on bone in the lateral aspect of the talus, and we'll go ahead and follow our wire placement. And again, a lot of times the wire will come out. You want to save that for finding your pilot hole again. I have found that the talus anchor placement is a tiny bit more difficult than putting it in the fibula, just because there is a little bit more soft tissue in the area. So we have the angulation. We'll take our second 4.75 millimeter anchor, and now we'll take the other end of our BioBrace and again thread it through. And at this point, this is where it does come in handy that this 4.75 millimeter twist and anchor, it is very snug, so I can give it a tug and it's not moving at all. Again, just because we don't have the direct visual confirmation of this anchor going in, we don't want any play once we find the position and the proper tension of actual inserting it into the talus. So now we'll take out the wire, and how I tension this is we will get it roughly to the point where we think we're going to need it for maximum tension, and I place the tip of the anchor directly against the pilot hole. You can feel the tension in the BioBrace. And at this point, just because the anchor does advance through the bone as you're putting it in, it does take the BioBrace with it, I've found that measuring back approximately 9 to 12 millimeters, depending on the size of the patient or how far the anchor may go in, is typically what you need for the advancement of the anchor. We do have the laser line available on the anchor, but again, without direct visual confirmation, the 9 to 12 millimeters is typically what I'm seeing for proper tension when inserting. So at this point, we have our BioBrace pulled to where it's taut with the tip of the anchor at the level of our pilot hole. And now we'll take our ruler and measure back roughly a centimeter from that point, which will account for the insertion and the advancement of the BioBrace as it's being placed. And one thing you want to make sure that you're doing with the implementation of the talus anchor is that you have your ankle in neutral position. A lot of times I will have my assistant hold the ankle at 90 degrees without any significant inversion or eversion, because this is, again, trying to recreate the natural ATFL course. And eventually, when we do get to the true shot and the all suture anchor placement for the Gould retinaculum, that's when we'll tighten it down a little bit extra, because those soft tissues will get a little bit of stretch over time and relaxation. So now you can see we have our anchor pulled back to the level approximately a centimeter back from the original point. And again, we can use fluoroscopic guidance to make sure that we're headed towards the correct position in our tailless anchor drilled hole. And again, we'll take our mallet, very gently tap, and we can confirm that we are indeed inside that drilled hole. So now we have contact with the anchor at the actual bone, and we start advance with the twisting mechanism. Again, a lot of times you will feel that squeak when the anchor actually starts to engage in the bone. With the cadaver here, don't always get that. But we can check on our ankle x-ray again. At this point, just like the previous anchor, I do not use these sutures. All right, and again, now we have our anchor implanted into the talus. Give it a quick tug. It's pretty well seated in there. So we'll take either 15 blade or a Mayo scissor or whatever you want to use. And again, this is a small portal that we're going through, but you want to try to cut it as flush as possible. And then we have our first part of the procedure done with the BioBrace implanted to recreate the natural course of the ATFL from the fibula to the talus. We can take our x-ray and see that we have a nice placement in the talus there. So now that we've placed our BioBrace from the fibula to the talus, and now we're getting ready to implant our all-suture anchor for the Gould modification. We already performed the debridement earlier of the anterior fibula, and we have our outline of the fibula on the lateral aspect and the inferior aspect, and we're placing this at pretty much a straight E to P angle at the level of the ankle joint. You have a couple different options here where you can use two separate two-limb suture anchors. I like to use the four-limb just for less of a footprint and making sure that we're not drilling into other parts of the fibula that already have an anchor implanted and having good seating of our one anchor here. So this is an all-suture anchor. This one has 4 limbs, 1.8 millimeter, and this is what we use to eventually shuttle the sutures through our accessory incision where we previously placed the bone anchors to perform the Gould modification. All right, so now we have our all-suture anchor situated in the anterior face of the fibula here, and this is going to be for our Gould modification. So our assistant will run the wire for the pilot hole back and forth several times. And then your assistant will take a mallet and use counter pressure against the heel. And we can see our anchor going in. Keep going. And then it will lock in place just like that. And we can see with our cannula on there, we'll pop out the sutures that are attached to the inserter. And then the handle pulls straight out, as so. And we can see we have our 4 limbs attached. And again, to seat it, you give it a gentle little tug. You can see we have good seating of the sutures within the fibula. And at this point, we are ready to shuttle these sutures through the extensor retinaculum to perform our Gould modification. This is the last time we'll be able to actually see anything arthroscopically as well, because once this tissue is imbricated, it pulls it directly to the anterior face of the fibula, so it's obscured by all of the extensor retinaculum and whatever remnant of the ATFL is being attached back down to this anchor spot. So when we're tying these down eventually, you do have the same to same, so we'll use our solid and our striped suture together. So these you can pick, since they're coming out of the same hole, you can pick either anterior or posterior. And again, it's obscured now, but we previously had our anchor placement through the small accessory portal here. You'll have 2 anterior to this and 2 posterior. So this is our eventual placement when we thread these sutures through. We're gathering the extensor retinaculum, anterior and posterior to our accessory portal that was previously created. So at this point, you can use a suture passer or just the needle, and you can reach with the needle driver. That is also an option. Okay, now you can see that we have all 4 of our sutures passed through the extensor retinaculum, and we have them placed percutaneously through the skin. So at this point, we can cut all of our needles off, and we're going to shuttle these subcutaneously through our central portal here that we have already created. So the reason that we perform the BioBrace bone anchor to bone anchor first is that that is kind of our resting tension in neutral position. And then since we're not attaching the true shot anchor to another bony interface, this is just gathering the soft tissues with the Gould modification. It does get a little bit of relaxation over time. So in this situation, we are dorsiflexing and slightly everting the ankle to be able to get a little bit more tension just with the soft tissue repair. So at this point, we have all of our sutures placed percutaneously through the skin, and we're going just deep to the skin and gathering the sutures through this central accessory portal that we already have in place. And you want to make sure that you're going just deep to the skin so you don't accidentally grab any nerve branches or any soft tissue structures that you don't want incorporated into this eventual knot. So now you can see we have all 4 of our suture strands passed through this central portion, and then at this point we're going to hand tie them down, and we'll imbricate the extensor retinaculum back up to our anchor that we previously placed in the anterior fibula. So at this point, the assistant in the operating room will hold the ankle in slight dorsiflexion and external rotation. And then again, same suture to same suture. We're going to hand tie these down, and then we're simply going to cut away our excess suture. And you can get some skin puckering sometimes just because we are bringing this tissue back up pretty much close to this anterior lateral arthroscopic portal. So to relieve some of that skin tension, take your hemostat just under the skin to relieve that tension, and you can get rid of that puckering. So the advantages of the all arthroscopic fluoroscopic technique for the Brostrom repair: obviously smaller incisions, lower chance of wound healing complications, infections, things along those lines, and ultimately with the minimally invasive approach, we can get a quicker return to activity, quicker weight-bearing time. So for post-op protocol for this procedure, a lot of times I will have 1 week of non-weight bearing with a splint, advancing into a cam boot for 2 additional weeks, and then my goal is to get these patients into an ankle brace by week 3 and starting physical therapy sometime in that period where they begin walking. If you are performing adjunctive procedures such as an OCD repair, peroneal tendon repair, things along those lines, it can alter the postoperative course. If we're just doing the ligament repair, then usually they're up and walking after about a week.